Thank you, Deepak, and thank you all. So let me begin with. So we started with the central nervous system. One of the very important topics in your central nervous system are a few repeated questions in your university exam. That is the reason why I started with the central nervous system. So to begin with, we already discussed elaborately on seizures, and in the last class, we just started with this very important diagram. So that is your multiple sclerosis explained in one single. We have explained the entire multiple sclerosis in a one single framework. So that we already saw in the last class. So what we are going to do today, our ultimate aim is to frame how to write your essay in your multiple sclerosis, as well as understand all the important pathology behind these all symptoms and signs which I have written in this one diagram. Clear? So let me quickly go through. So what is a multiple sclerosis? As per your definition given in your Davidson textbook. So what he tells is multiple sclerosis is an important cause of long-term disability in adult, which is nothing but, I'll tell you very easily, multiple. What is the word multiple means? நிறைய இடத்துல. So there are multiple places where you are going to have signs and symptoms. Sclerosis அப்படின்னா என்ன? Some degeneration. Sclerosis means degeneration. But that word doesn't tell what gets degenerated. Here, the one which is going to get degenerated is your myelin. So myelin is produced by oligodendrocytes, and these myelin are the main target of the disease multiple sclerosis. So what is the main target? In myelin, you have something called as myelin basic protein. You have something called as myelin basic protein. So what happens is there is some problem. There is some problem in this myelin basic protein, because of which your myelin is getting affected. Because of your myelin getting affected, you are going to have a multiple sclerosis. Now you can understand what happens, right? Now coming to the feature. So what is a multiple sclerosis? A multiple sclerosis is nothing but it is a autoimmune disease. It is a autoimmune mediated disease. Autoimmune mediated disease, and this is going to be present especially in the females. So when you're going to see the incidence, it is twice as common as female அப்படின்ட்டு சொல்றாங்க. But when you consider India, it is going to be 3:1 ratio. So female is to male ratio is 3:1. So what I'm telling, so it is more common among females in the ratio of 3:1 in India. So what are the risk factors? So pathophysiology ஒரு பெரிய பெரிய ஒரு பேராகிராஃப் கொடுத்துருக்கோம். பட் நமக்கு என்ன தேவை அப்படின்னு நம்ம பார்த்தோம்னா வெரி வெரி ஸ்மால் திங் இட் இஸ் ரிக்வயர்ட். ஸோ தெர் ஆர் டூ இம்பார்ட்டன்ட் எவிடன்ஸ் தட் இஸ் கோயிங் டு பி பிளேயிங் அ இம்பார்ட்டன்ட் ரோல் இன் மல்டிபிள் ஸ்க்ளரோசிஸ் pathology. One is genetic, other is a environmental factor. Now when you ask me what genetic factor is going to be playing, what is going to be the environmental factor? So the prevalence of multiple sclerosis is low near the equator and increases in the temperate area. அப்ப என்ன மீனிங்? சன்லைட் எங்க இருக்கோ அங்க வந்து there is going to be a less multiple sclerosis. And when you move towards the temperate area, when you're going to move towards the temperate area, the prevalence is going to increase. That means what is present in the sunlight? Sunlightல நமக்கு எதுவும் இல்லை, but vitamin D அதோட activationக்கு sunlight is necessary. So what the experts think is vitamin D is one of the factor which is going to be a risk for the multiple sclerosis. So first risk factor நம்ம என்ன பார்க்கிறோம்? vitamin D deficiency. Second risk factors என்னன்னு பார்த்தோம்னா Epstein-Barr virus. Epstein-Barr virus வந்து ஓகேவா, exposure to Epstein-Barr virus is also playing an important role in the pathophysiology of your multiple sclerosis. ரெண்டு பாயிண்ட் தான் இதுல நீங்க எடுத்துக்க போறீங்க. நெக்ஸ்ட் ஒன், இட் இஸ் autoimmune disease ன்னு சொன்னேன். அப்ப இம்யூனிட்டியில ஏதோ ஒரு ரீஜன் இஸ் கோயிங் டு பி அஃபெக்டட். வாட் இஸ் தட் ரீஜன்? இஃப் எனிவன் நோ, HLA DRB1. ஸோ இது 3 பாயிண்ட் தான் நீங்க நான் வச்சுக்க போறீங்க ரிஸ்க் ஃபேக்டர்ஸ்ல. என்னன்னா, ஒன்னு விட்டமின் டி டெஃபிஷியன்சி, செகண்ட் இஸ் யோர் Epstein-Barr வைரஸ், தேர்ட் இஸ் யோர் HLA DRB1. ஓகேவா? ஸோ விட்டமின் டி வந்து எங்க லெஸ் காமனா இருக்கு அப்படின்னு பார்த்தோம்னா இந்த டெம்பரேட் ஏரியாஸ். அதுலயும் டெம்பரேட் ஏரியாஸ்ல மோர் காமன் ஏரியா எங்கன்னு பார்த்தோம்னா நார்த் அமெரிக்கா. ஸோ நார்த் அமெரிக்கா இஸ் the place where you can see this multiple sclerosis increased. ஓகேவா? Now coming to the pathophysiology. I'll tell the entire pathophysiology. So before moving into the pathophysiology, you're going to have a nerve. Okay, so this is going to be your nerve. This is going to be your axon. So between your axon, there is in the above the axon, you're going to have a myelin coverage. So there is a myelin sheath and you're going to have a dendrite. Okay, so in the myelin sheath there is a demyelination. So what is the point? What is happening in your multiple sclerosis? There is a demyelination. So because of demyelination, what happens? Your myelin is lost. Your myelin is lost. Okay, so what happens is there is going to be an inflammation. Because of inflammation, there is going to be a demyelination. Because of demyelination, okay, you're going to have two important things. One is going to be gliosis, and other thing is going to be either it can get gliosed or you can have a remyelination. Who is going to do remyelination? Oligodendrocyte is going to do remyelination. Oligodendrocyte is going to do remyelination, and which is going to go gliosis. So astrocytes are important to form gliocytes. Astrocytes are important to go into gliosis. So your myelin is produced by your oligodendrocyte. So remyelination nadakanona, you need to have oligodendrocyte. But inge enna agudhu, oligodendrocyte act பண்றது எப்படின்னா by myelin basic protein. இந்த myelin basic protein target பண்ணது your autoimmune mediated disease. So because of it, there is no remyelination that is going to occur. Because of no remyelination, certain problems are going to be there. Very simple. You all know that the conduction, okay, normal nerve conduction occurs at a speed of usually 70 to 90 millimeter per second. But fortunately, we have this myelin coverage in our nerves. Because of this, what happens? There is going to be a increase in the speed of conduction. Or by how much? 1 meter per second மாறுது. அப்ப 90 meter per second இருந்து 1 meter per second கன்வெர்ட் பண்றது யாரு? உங்க myelin. அப்ப என்ன ஆகுது? There is a loss of speed in the nerve transportation, nerve signal transportation. அப்ப இங்க பேசிக்கா என்ன ஆகுது? From without reading anything, what I can understand or what you can understand is there is a slowness in the conduction of the nerve fiber signal. Okay, so அதுதான் இதோட ultimate pathology. So one important thing what you have to know is because of this demyelination, what happens? It is going to be permeable too. It is going to be permeable inside your blood-brain barrier. So blood-brain barrier ulla permit agudhu. Seri, once this demyelinated nerve sheath is going to enter into the blood-brain barrier enter ஆகுதுன்னா அதுல என்ன நடக்குது? இததான் நம்ம இப்ப entire pathophysiologyல நம்ம பார்க்க போறோம். ஓகேவா? Shall I start with இது வரைக்கும் ஏதாவது டவுட் இருக்கா? If you are not having any doubt up to this, I will go with the next one. So what happens is there is a vascular endothelium. ஓகேவா? இந்த vascular endothelium, every nerves will be having a blood supply. And the blood supply க்கு போற vascular endotheliumல what happens? Your T cells attacks. Your T cells are going to attack. Because of the T cells attacking on the vascular endothelium, because of your T cells that are going to attack on the vascular endothelium, what happens is on the surface of your T cells, you are going to have a substance called as CAM. What is CAM? Cellular adhesion molecule. What is CAM called as? Integrin. So what happens is your T cells will be having a structure called as integrin, or this structure integrin are going to get attached with the vascular endothelium. அப்ப vascular endothelium affect ஆகுது, it is going to supply na அங்கேந்து என்ன ஆகுதுன்னா உங்க நர்வ்ஸ்க்கு போகுது. இப்ப you all know that அந்த நர்வ்ஸ்ல வந்து myelin இருக்கு. So you are going to have a myelin over the nerves. இந்த myelin என்ன பண்ணுதுன்னா this is going to T cells are going to attack the myelin sheath. Your T cells are going to attack the myelin sheath. Once it attacks your myelin sheath, it is going to produce a cytokine called as TNF alpha, tumor necrosis factor alpha, because tissue necrosis factor no சொல்லுவோம். இந்த tissue necrosis factor alpha வந்து இங்க அட்டாக் பண்றப்ப it is going to release nitric oxide. It is going to release nitric oxide. Okay, now what happens is once you are going to have this particular TNF alpha attacking, TNF alpha இங்கயோட நிறுத்தாது. Once TNF alpha is going to attack your, okay, once your TNF alpha is going to attack, what it is going to do is, I'll show you one more thing. Okay, I'll show you a picture. So that will be helping you to clearly understand. So what happens is, this is your normal myelinated axon. So this is going to be your action potential. Once it is going to get demyelinated, what happens is, there is going to be a problem in the conduction. But அங்கயோட நிக்கல, இப்ப என்ன ஆகுது, sodium channels are going to get affected. So what happens in a chronically demyelinated axon? So it's going to be slowly, the difference between one axon to another axon is slowly increasing, and your sodium channels are going to get open. Sodium channel open ஆகறப்ப என்ன ஆகும், your frequency of action potential will be increasing. But frequency of action potential increase ஆனா மட்டும் போதுமா? It should be at the same time able to transmit the impulses from one axon to other axon. Since here there is no myelin sheath, because of which what happens, the speed of conduction is decreased. Because the speed of conduction is decreased, what happens, the conduction is going to be slowly, it is increased conduction frequency but decreased signals reaching your conduction, because of which the axons are going to slowly get degenerated. So can you understand? So because of it, what happens, your axons are slowly going to get degenerated. Your axons are slowly going to get degenerated. Because of all these things, your axons are going to get degenerated. Along with the degeneration of axons, what happens, there is going to be a neuronal loss. Because of it, there is going to be a neuronal loss. இது எல்லாம் சேர்ந்து அல்டிமேட்டா என்ன பண்ணுனா, there is going to be a myelin degeneration. There is going to be ultimately causing myelin degeneration. Okay, this is going to be cause ultimately myelin degeneration. So இது வந்து T cell mediated. But remember, just T cells are not going to be the villain in this story. You also have another one, that is your B cells. What happens is, your B cells of your brain are going to produce antibody against this MOG, that is myelin oligodendrocyte glycoprotein. So if B cells என்ன பண்ணுது, ரெண்டாவது villain, he is going to create antibody against the myelin oligodendrocyte glycoprotein. So because of it, what happens, so இது நல்லதுதான். இது என்ன பண்ணும்னா, இந்த myelin oligodendrocyte glycoprotein is going to cause a repair. So இவன் என்ன பண்றான், நல்லது பண்றேன்னு நினைச்சு he is going to produce antibody. So it is going to trying to repair the degenerated degenerated nerves. So அதுக்கு பேர் தான், you call it as gliosis. அதுக்கு பேர் தான் gliosis. Now you remember, I told you, right, there is going to be a two process. Oligodendrocyte causes remyelination, astrocyte causes gliosis. But oligodendrocyte la தான் இங்க problem இருக்கு. So remyelination நடக்காது. But astrocyte நால என்ன ஆகுது, there is going to be a gliosis. What is a gliosis? There is a formation of periventricular plaques. So there is going to be a formation of periventricular plaques, PLAQES. So plaques, இந்த மாதிரி periventricular plaques form ஆகிறத நம்ம MRIல எப்படி தெரியும்னா, in MRI you are going to see a Dawson finger-like appearance. Dawson finger-like appearance. Dawson is the one who identified this particular sign first. It will be like a finger-like appearance. Therefore, it's called as Dawson finger-like appearance on the MRI. So first என்ன ஆகுது, T cells attack பண்ணுது. Second என்ன ஆகுது, B cells வந்து ரிப்பேர் பண்ண ட்ரை பண்ணுது by myelin oligodendrocyte glycoprotein. Third என்ன ஆகுது, உங்களோட formation of periventricular plaques. அப்ப MRIல எப்படி தெரியும், டாவ்சன் ஃபிங்கர் தெரியும். ஸோ இது வந்ததுக்கு அப்புறம் தான் நாலாவது இம்பார்ட்டன்டான பாயிண்ட் என்னன்னா, உங்களுக்கு always you know that nerve conduction க்கும் temperature க்கும் ஒரு relationship இருக்கு. Nerve conduction decreases with the increased temperature. Nerve conduction decreases with the increased temperature. அப்ப இங்க என்ன ஆகுது, ஆல்ரெடி உங்க myelin sheath damaged இருக்கு. Already there is a damage in the myelin sheath. Unfortunately there is an increase in temperature in the surrounding area, maybe summerல இருக்கலாம். அப்ப என்ன ஆகுதுன்னா, there is going to be increase in the heat exposure. Once heat exposure is going to be increased, this is going to ultimately cause decrease in the conduction of the nerve signals. So since there is a decrease in the conduction of nerve signals, so this is called as Uthoff's phenomena. So அப்ப என்ன ஆகும்னா, உங்களுக்கு இந்த features of நம்ம இப்ப futureல படிக்க போற அந்த symptoms எல்லாமே increased-ஆ இருக்கும் on increase in the heat exposure. This is called as Uthoff's phenomena. ஓகேவா, இதுல ரெண்டு இருக்கு. ஃபர்ஸ்ட் ஒரு பார்ட் ஆஃப் த பிரெயின் மட்டும் தான் அஃபெக்ட் ஆகும். அதுக்கு பேரு கிளினிக்கல் ஐசோலேஷன் சிண்ட்ரோம். ரேடியாலஜிக்கலா உங்களுக்கு ஐசோலேட்டடா இருந்தா அதுக்கு பேர் ரேடியாலஜிக்கலி ஐசோலேட்டட் சிண்ட்ரோம். பட் இதெல்லாம் இனிஷியல் பீரியட் ஆஃப் டைம்ல தான். The name itself tells that there is going to be a multiple sclerosis. அப்ப different areas of the brain are going to get sclerosed. அதனால அதுக்கு பேர் நம்ம என்ன சொல்றோம், மல்டிபிள் ஸ்க்ளரோசிஸ்னு சொல்றோம். சோ இனிஷியல் பீரியட்ல வெறும் ஒரு பார்ட் தான் அஃபெக்ட் ஆகும். சோ வெறும் கிளினிக்கல் சைன்ஸ் மட்டும் இருந்தனா you call it as clinical isolation syndrome. வெறும் radiological isolation மட்டும் இருந்தா you call it as radiologically isolated syndrome. Okay, next we are moving to the clinical features. So இப்ப நம்ம பார்த்த இத தான் வந்து அவன் ஃபுல்லா அந்த paragraphல கொடுத்திருப்பான். So there is nothing difference in what I told and what is in the textbook. So same thing I have differentiated and let you know. So now coming to the clinical features. Before going into clinical features, did you all understand what is a pathophysiology? Can we move into the next one? Someone, can you put in the chat box? Shall we move to the next one? Thank you. So I'm just going to move towards the next one. So that is the clinical features. So what happens is, usually this is more common among the North American descent. I already told you temperate regions la இருக்கற அவங்களுக்கு தான் வந்து most common-ஆ வருது. So usually diagnosis வந்து unexplained CNS lesions with separated in time and space அப்படினாலே it's going to be MS. So ஒரு particular demonstration கிடையாது. ஓகேவா, சோ இங்க நான் சொன்னேன் பாருங்க. So this means that two or more clinical relapses affecting different parts of your nervous system, you call it as clinically isolated syndrome. அதுக்கப்புறம் ரேடியாலஜிக்கலா உங்களுக்கு வந்ததுன்னா you call it as a radiological isolated syndrome. So இதுதான் ஃபர்ஸ்ட் பேராகிராஃப்ல கொடுத்திருக்கோம். So what is the age of onset? Usually fourth decadeல தான் usually it will be coming. So after the age of 60 years is rare. Okay, either before the puberty or after the 60 years age group is very rare. So symptoms and signs வந்து it will be evolving from days to weeks and it will be resolving more than 1 week. Okay va, it will be resolving over a week or month. Rare தான் stroke like presentation வரைக்கும் போகும். Okay, now இந்த picture எடுத்துக்கோங்க. இந்த pictureல இருந்தா நம்ம ஆரம்பிக்க போறோம். First, sensory system. So நமக்கு we have different nervous systemல அதுல sensory system தான் first affect ஆகிறது almost 35%. So sensory system வந்து almost 35% of the people first it is going to get affected. So what are the sensation or what are the symptoms you will be having in the sensory system? Number one, there will be paresthesia. There will be pin and needle sensation. So இதெல்லாம் நீங்க அப்படியே நோட் பண்ணிக்கலாம். So first symptom, signs and symptomல sensory system பார்க்கிறோம். Sensory systemல என்னென்ன symptom இருக்கு? Paresthesia, pin and needle pin and needle sensation will be there. And third one, there is going to be sensory level involvement, that is your spinal cord involvement. And fourth is going to be multifocal pain. There is going to be multiple pain areas. Okay, pain focus irko. Okay, so that is going to be as far as your sensory nervous system is concerned. Next, where we are going to move into eyes. So in the picture la paranga, kannla enna irukku? Optic neuropathy, sixth nerve palsy, or you call it as Webino. Do you remember what is Webino? I told you last time. Do you remember what is Webino? Okay, I'll tell you now. So what happens is there is a decrease in the visual acuity. I'll tell you from first what are the visual symptoms which you are going to get. So what happens? There is a decrease in the visual acuity. Unilateral than your bilateral. Okay, then there is going to be decrease in the color perception. There is a decrease in the color perception. So in the madri neenga exam it will be easy for the examiner to correct, as well as it will be easy for you to remember. First sensory system mudichom, அடுத்தது optal visual system நம்ம பார்க்கறோம். இதுல first என்ன ஆகுது, நம்ம ஒரு optal case presentationலாம் நீங்க பண்ணிருப்பீங்க. அதுல first நம்ம என்ன பார்ப்போம், visual acuity சொல்வோம், அப்புறம் color perception சொல்வோம். So இங்க என்ன ஆகுது, there is a decrease in the color perception. ஓகேவா? So இப்போ ஒருவேளை there is going to be a visual acuity loss, there is a color perception loss. With this, if you are going to have a uveitis, if you are going to have a uveitis, then think of sarcoidosis. But inge vande uvea will be normal. There is not going to be any infection in the uvea ultimately. So uvea is going to be normal. Your fundus is going to be maximum normal, or sometime rarely there can be papilledema or papillitis. Okay, and visual loss, vision loss வந்து பாத்தீங்கன்னா யூனிலேட்டரலா இருக்கலாம். There can be periorbital pain. Periorbital pain, especially எப்ப periorbital pain வரும்னா when you are going to do any movement. So it is going to be increased on movement. Okay, then internuclear ophthalmoplegia. So this is what next I am going to talk about. Internuclear ophthalmoplegia. This is what I am going to talk about. What is internuclear ophthalmoplegia? Because this one, if you read in your textbook, nothing can be understood. So in the question, Viva la kette neenga answer pannengana, for sure you will be getting good score in your Viva. Okay, what is this internuclear ophthalmoplegia? So there is a lesion that is going to occur in the medial longitudinal fasciculus. So there is a lesion that is going to occur. So what happens? There is a lesion that is going to be occurring where in the medial longitudinal fasciculus. Okay, so inge or lesion ஏற்படுறதுனால என்ன ஆகுது அப்படினு பார்த்தோம்னா, it results in the impaired adduction of one particular eye. So ஒரு particular eye la adduction இருக்காது. For example, this is going to be your normal eye, isn't it? So normal eye இப்படி. So இப்போ ஒருவேளை இந்த side movement பண்ணீங்கன்னா, so what happens? Your eyeball is going to be moved towards this side. Your eyeball is going to move towards this side. But what happens in a internuclear ophthalmoplegia? So medial longitudinal fasciculus is going to be there. அதனால என்ன ஆகும்னா, ஒரு பக்கம் movement of adduction will be good, but இந்த sideல adduct, okay, when you're going to adduct this side, okay, so in the eye la dhaan problem. So let's keep it as a right eye. Okay, this I will keep this as a left eye na vechikren. So if I am going to have this as a left eye, so in the kanla mattum problem endha enna aguna, in the kanna adduct agum, but in the kanna adduct agadu. Okay va? So or if this eye is going to be a problem and the right eye is going to be a problem, in the kanna centraliye irukum, verum in the kanna mattum dhaan adduct agum. So inge adduction nadakala. So there is no adduction, isn't it? So that is what impaired adduction of one particular eye, and contralateral eye will be moving normally in this patient. So in the kanna normally move agudhu, in the kanna that your right eye is alone not moving. So why this is going to occur? Let me explain you. So what happens? This syndrome is called as 1.5 syndrome. So idu 1, idhula half da irukku, and you call it as 1.5 syndrome. So examல 1.5 syndrome அப்படின்னு உங்களை கேட்டு வைக்கிறான்னு வைங்க. Don't worry, it is very easy. So what happens? I already told you in multiple sclerosis, what is going to be your issue? In a multiple sclerosis, there is going to be a plaque formation in the periventricular area. So there is a formation of periventricular plaque. இந்த plaque வந்து ஒருவேளை 6th nerve nucleus, 6th nerve nucleusல இந்த plaque இருந்ததுன்னா, this is going to affect the abduction. Can someone put in the chat box, how do you remember the nerve supply of your eye? Okay, muscles of eye ku nerve supply ku you have one mnemonic, right? So can someone put it in the chat box? Can someone put it in the chat box, please? I'll wait for a few minutes, no problem. So SO4, LR6, rest 3. Okay, SO4, that is your superior oblique, that is going to be supplied by 4th nerve. So 6th nerve enna supply பண்ணுது? LR6. Okay, LR6 தான் வந்து பாத்தீங்கன்னா it is going to be supplied. LR வந்து என்ன action? What is the action of your lateral rectus muscle? Okay, so lateral rectus muscle ஓட action என்ன? Can someone? What is the action of your lateral rectus? Lateral rectus is responsible for abduction. So lateral rectus oda primary இது என்னது? Abduction. So 6th nerve nucleus affect ஆகிறதுனால it is going to affect your abduction. So I have already mentioned, right? It is going to be affecting your abduction. So because of which there is an inability to move your eye laterally. 6th nerve nucleus is also connected to the contralateral 3rd nerve nucleus. Okay, 6th nerve nucleus is contralaterally connected with the 3rd nerve nucleus, which helps in the adduction of the opposite eye. So I'll tell you. So this is going to be your this is going to be your brain. Inga enna agudhu? You have the 6th nerve nucleus. So idu vandu 3, you are going to have a PPRF. You have this one called as PPRF, and you're going to have a first, we are going to have here, you're going to have a 3rd nerve, and here also you're going to have a 3rd nerve. So what happens? This 6th nerve is contralaterally connected to the 3rd nerve. 6th nerve is contralaterally connected to the 3rd nerve. Because of the 6th nerve contralaterally connected to the 3rd nerve, opposite side la இருக்கிற movement வந்து ப்ராப்பரா இருக்கும். So உங்க 6th nerveல இருந்து வர்ற lateral movement of eye மட்டும் ப்ராப்ளம் ஆகுது, but the adduction of the opposite eye is going to be happening very good. So இங்க வந்து lateral movement affect ஆகுது, opposite sideல என்ன இருக்கு? நார்மலா இருக்கு. Hence opposite eye ஓட adduction is going to get affected. I'll tell you again, there's an inability to move your eye laterally in the 6th nerve nucleus. So what happens? Because of this, okay, there is going to be a contralateral connection with the 3rd nerve nucleus. 6th nerve nucleus la இருந்து contralateral உங்களுக்கு 3rd nerve nucleus போகுது. அப்ப இந்த கண்ணுல என்ன ஆகுதுன்னா, okay, you all know that two muscles are going to hold the eyeball together. So ஒரு சைடுல medial rectus, ஒரு சைடுல lateral rectus. So what happens? இந்த கண்ணோட lateral rectus affect ஆயிருக்கு, இந்த கண்ணோட lateral rectus affect ஆயிருக்கு. அப்ப but what happens? The person is trying to move towards your eye. So இங்க towards your eye move ஆகும்போது என்ன ஆகும்? Okay, opposite sideல வந்து it has to move to the adduction. So இங்க வந்து your lateral rectus ஓட performance is the abduction. So இந்த கண்ணுல நீங்க abduction பண்ண ட்ரை பண்றீங்க, so இந்த சைடு மூவ் பண்ண ட்ரை பண்றீங்க, பட் நடக்கல. So ultimately இந்த கண்ணுல என்ன ஆகணும்? இந்த கண்ணு abduct ஆச்சுனா this eye should go for adduction. This eye should go for adduction, isn't it? When this eye, let's name it as a right eye, when the right eye is going to abduct, okay, left eye has to adduct. This is the common rule. But what happens here? There is going to be a lateral rectus palsy. So lateral rectus varlana, when the inability to move the eye laterally, your 6th nerve nucleus is also connected with the contralateral 3rd nerve nucleus. That is your medial rectus. So medial rectus odayum connect ஆயிருக்கு of opposite eye. Per se I will take it as a left eye. So right eye oda அப்டக்ஷனும் லெஃப்ட் ஐயோட அடக்ஷனும் சேர்ந்து நடக்கணும். பட் இங்க என்ன ஆகுது, ரைட் ஐல அப்டக்ஷன் நடக்கல, லெஃப்ட் ஐல என்ன ஆகணும், அடக்ட் பண்ணணும், அந்த அடக்ஷனும் ப்ராப்ளம் ஆயிடுது. அப்ப when there is a affection, when there is going to be a problem in the adduction, your abduction is going to be occurring more. அப்ப abduction நிறைய occur ஆகுதுன்னா what happens, there is going to be movement of your eyeball towards the lateral side in the opposite eye. So therefore there is going to be a opposite eye adduction is going to get affected. So sixth nerve nucleus நால எந்த சைடுல அஃபெக்ட் ஆயிருக்கோ அந்த சைடுல அப்டக்ஷன் நடக்குது. சோ எந்த சைடுல அஃபெக்ட் ஆகலையோ அந்த சைடுல அடக்ஷன் நடக்குது. So there is going to be a opposite eye is going to get adducted. Opposite eye is going to get adducted. Very clear? So your opposite eye is going to get adducted. So I think I'm very clear. If you have any doubt in this, please just put in the chat box. Again also I will repeat. So there is a plaque in the sixth nerve nucleus, because of which the abduction is not going to occur. So that is your lateral rectus sort of function is not going to get not going to function. At the same time, though there will be inability to move your eye laterally because of the sixth nerve nucleus. Also your sixth nerve nucleus is connected with the contralateral third nerve nucleus. Contralateral third nerve nucleus oda connect ஆயிருக்கு. Contralateral third nerve nucleus என்ன பண்ணணும், adduct பண்ணணும். But since here there's a opposite eye adduction is going to be affected, there is going to be abduction. இது first plaque sixth nerve nucleus la. Similarly, there is a second plaque in the same side medial longitudinal fasciculus that is going to affect your third nerve. So in the side layum third nerve layum உங்களுக்கு என்ன ஆகுது, there is a plaque. வெறும் sixth nerve ல மட்டும் தான் plaque இருக்குன்னு நினைச்சீங்க, but sixth nerve plus third nerve லையும் plaque ஆகுது. இப்ப third nerve ல plaque இருக்கிறப்ப என்ன ஆகும், ஓகேவா? Because of this, okay, there is not going to be any movement at all. இந்த சைடுல lateral rectus மட்டும் affect ஆகல, இந்த சைடுல medial rectusம் affect ஆயிருக்கு. Okay, but இந்த சைடுல வந்து பாத்தீங்கன்னா medial rectus is also affected, lateral rectus is also affected. ஓகேவா? ஏனா இப்ப இந்த sixth nerve affect ஆகறப்ப ஆட்டோமேட்டிக்கா signal doesn't reach your third nerve. Therefore sixth nerve லயும் problem இருக்கும், third nerve of the opposite side லயும் problem இருக்கும். Therefore okay, therefore no adduction and no abduction நம்ம பார்த்தோம். இப்ப என்ன ஆகுது, so we can have it on the right side and left side. So right eye-ல third nerve nucleus is not going to function. Third nerve nucleus na enna, it is a medial rectus. First lateral rectus மட்டும் தான் affect ஆகலன்னு நினைச்சோம், இப்ப medial rectus affect ஆகல. அல்டிமேட்டா என்ன ஆகும், there is no movement. So இந்த கண்ல மூவ்மெண்ட் இருக்காது. அது இந்த கண்ல எப்படி இருக்கும்னா, so உங்களுக்கு sixth nerveல இருந்து information is passed, but third nerveல இருந்து தான் போக மாட்டேங்குது. அப்ப sixth nerveல இருந்து போறது யாரு, lateral rectus. third nerveல இருந்து போறவங்க யாரு, medial rectus. இங்க medial rectus மட்டும் தான் affect ஆகுது, lateral rectus is not affecting. Therefore in the opposite eye what happens is there is going to be a abduction. So opposite eye will be causing abduction. Same eye வந்து என்ன ஆகும், where the lesion is there அந்த சைடுல இருக்க கண்ணுல எந்த மூவ்மெண்ட்டுமே இருக்காது, opposite sideல என்ன ஆகும், abduction இருக்கும். Because of this what happens, you are going to have this 1.5 syndrome. What is 1.5 syndrome? Ipsilateral sixth nerve palsy, ipsilateral medial longitudinal fasciculus lesion, but contralateral abduction of the eye, but adduction ஆகுது. ஓகேவா? சோ கான்ட்ராலாட்டரல் சைடுல என்ன ஆகுது, அப்டக்ஷன் ஆகுது, பட் அடக்ஷன் ஆகல. சோ இதுல ஏதாவது டவுட் இருக்கா உங்களுக்கு? If you have any doubt, please mention in this. I will clear with this at this point itself and go to the next one. Can someone respond? Deepak, Deepal, Chandika, Anu. Someone, can you respond in the chat box? Deepak, thank you if it is clear. Okay, this is very important concept. So this is what your sixth nerve palsy, which is going to be occurring, and this is called as 1.5 syndrome. Again, I'll repeat the last 3 points of 1.5 syndrome. There is a ipsilateral loss of the sixth nerve, and there is a ipsilateral loss of the medial longitudinal fasciculus. There is a contralateral abduction is alone present, adduction is lost. So in the 3 point that at the end of the day, you are going to remember for this ophthalmoplegia. So in the picture, the optic neuropathy and ophthalmoplegia, 1.5 syndrome. What this 1.5 syndrome is going to tell you: sixth nerve ipsilateral palsy, medial longitudinal fascicular lesion on the ipsilateral side, contralateral adduction is out, only abduction is going to occur. With this, I'll move to the next one. So what happens? So you would have seen in this picture that you're going to have a spastic weakness with upper motor neuron lesion. So there is going to be a spastic weakness of your muscle. Okay, there is a spastic muscle weakness. That is what I have mentioned here as subacute loss of function of your upper limb. So there is going to be a spastic weakness in the features of the upper motor neuron lesion. There is also facial nerve lesion is going to be present. What happens? Because of the lesion that is going to occur in the 7th nerve in your pons. Okay, facial nerve is going to affect that. But one thing you have to remember here is there is a taste sensation that is going to get preserved. There is a taste sensation that is going to be getting preserved. Next one is ataxia. So there is going to be ataxia. So gait ataxia. Edinala yerpadudhu? Paleo-cerebellum getting affected. What is a truncal ataxia? Archicerebellum affecting, and scanning of speech will be there. Next one, the vertigo deafness. காது கேட்காம போகும். எதனால? 8th nerve lesionனால. There will be trigeminal neuralgia. So 5th nerve lesion. அப்ப நீங்க எப்படி நான் வச்சுக்கலாம்? First நீங்க 6th nerve lesion, then you read about 7th nerve lesion, then you read about 8th nerve lesion, 5th nerve damage ஆகுது, that is trigeminal neuralgia. Then glossopharyngeal neuralgia இருக்கும், that is your 9th cranial nerve. So what will be the glossopharyngeal nerve damage? There will be a pain on swallowing. There will be a pain on swallowing. Then comes the very important sign that is going to be present in the neck. That is your Lermit sign. What is this Lermit sign? So this is also seen in the Debs dorsalis and cervical spondylitis. So on flexion of your neck, there will be a shooting pain in your leg. So what happens? On neck flexion, when you're going to do a neck flexion, what happens is there is going to be a radicular pain or a shooting type of pain which is going to be occurring in the legs. So that is called as Lermit sign. Is it clear? Facial myokymia. So what happens is in your face there will be a flickering movement of your facial muscles. So that is called as facial myokymia. Then what happens? I have told something about the urinary symptom. That is your bladder hyperreflexia. So what happens? Bladder is going to be having detrusor muscle. Normally enna aguna urine incontinence, nocturnal enuresis la solrolla, anga vandu what happens is your detrusor sphincter vandu loose aidum. Okay, detrusor sphincter vandu loose aidum, plus there will be a loss of inhibitory control of your urinary incontinence. Okay, so urinary and the bladder vandu the reflex vandu hyperreflexia va irukum. So this is going to be your muscle, so of your urinary bladder. Idhula hyperreflexia va irundha enna agum? So there is going to be a urinary incontinence. So that is what you call it as detrusor hyperreflexia. So aduthathu detrusor sphincter dysenergia. So detrusor muscle, aduthathu you are going to have this detrusor sphincter. So in the detrusor muscle contract agum, ஆனா என்ன ஆகும்னா இந்த ஸ்பிங்டர் ரிலாக்ஸ் ஆகாது. ஓகே, டெட்ரூசார் மசில் கான்ட்ராக்ட் ஆகுது, பட் உங்க ஸ்பிங்டர் இருக்கு பாத்தீங்களா, அது வந்து ரிலாக்ஸ் ஆகல. சோ அப்ப என்ன ஆகும்? யூரின் போற மாதிரி நமக்கு ஒரு எரிச்சல் இருக்கும், ஆனா யூரின் வில் பி ரிட்டென்ஷன் வில் பி தேர். சோ யூரின் வர்ற மாதிரி சென்சேஷன் இருக்கும், பட் யூரின் வராது. சோ திஸ் இஸ் கோயிங் டு காஸ் urine retention. So this is going to cause urine retention. Okay, whenever there is a urine retention, there can be infection. What is that infection called as? Cystitis. Urinary bladder infection is called as cystitis. Therefore there is an increased incidence of cystitis. Okay, so with this Okay, apart from this, you have to remember other things and also explanation now Uthoff phenomena theriyano. Sixth now optic neuropathy and ophthalmoplegia eppadi irukku theriyano. Lermit's sign theriyano. Next one, there is a neuropathic pain. So that I already told you, sensory symptom la. Apra urinary symptom la bladder hyperreflexia irukku. Apart from it, you will be having a sexual dysfunction. You will be having ataxia, dysarthria, tremor. These three together called as Charcot's triad. Idu varaikum clear? So once this is over, we are going to come to the end of the clinical features. So now we are already at the end of the clinical features. Next, we are going to go for the all the diagnosis criteria. Up to this, is it clear? Can someone put in the chat box so that I can continue with the next segment of the class? Thank you. So now we are moving towards the diagnosis. So before going into a diagnosis, what usually we wanted to do is we wanted to score the system. How we are going to score it? By using expanded disability severity score. Expanded disability severity score. So what is this expanded disability severity score, or otherwise called as EDSS? So you are going to score the patient based on their action. So we have this 3.5, 9, 9.5, 10. These are the 4 scores which we are going to give. So 10 na vandu pathina death aiduvanga patient. 3.5, how you are going to call it as 3.5? When the patient is able to walk, when the patient is ambulatory, when the patient is able to talk, when the patient is able to talk, when the patient is able to drink. Okay, then you call it as 3.5. When you give it as 9, when the patient is going to be bedridden, when the patient is going to be bedridden. Or number 2, when the patient cannot talk, when the patient cannot talk. And number 3, when the patient cannot drink. Okay, you're going to call it as a score 9. And when you have a score 9.5, when the patient is just bedridden for a long period of time, then 10 ultimately it is going to be dead. This is called as expanded disability severity score. Next, you have this revised Donald score. So your revised Donald score is page number 1109. You can take that. So other I will explain you in detail. Okay, so idhila the revised போறதுக்கு முன்னாடி what you should know is you should know what is relapsing multiple sclerosis. ஏனா இந்த இதுல வந்து பாத்தீங்கன்னா you will be able to see their terms like relapsing multiple sclerosis அப்படினு சொல்வாங்க. What is the relapsing multiple sclerosis? What is the meaning of relapsing multiple sclerosis? Relapsing na example I will tell you. So January, then there is going to be in April, then July. So January 2019 la உங்களுக்கு ஒரு இது வருது, ஏப்ரல்ல கம்மியா இருக்கு, திரும்பி ஜூலைல வருது. So இது என்ன ஆகுது? So ஜான்வரியில ஒரு ஸ்பாஸ்டிசிட்டி இருக்கு, ஏப்ரல்ல ஒரு இன்கான்டினன்ஸ் இருக்கு, ஜூலைல ஒரு விஷுவல் அக்விட்டி டிக்ரீஸ் ஆகுது. இந்த மாதிரி ஒன்னொன்னா டிக்ரீஸ் ஆகுதுன்னா you are going to call it as a relapsing multiple sclerosis. relapsing multiple sclerosis. அடுத்தது secondary progressive multiple sclerosis அப்படின்னா என்னன்னா, so இந்த மாதிரி ஒரு ப்ராக்ரஸ் இருக்கு. Okay, there is going to be a multiple sclerosis. So ஒரு ஏரியா அஃபெக்ட் ஆகுது. First there is a spasticity, second ஒரு incontinence இருக்கு, ஜூலைல ஒரு விஷுவல் அக்விட்டி டிக்ரீஸ் ஆகுது. So இந்த மாதிரி ஸ்டெப் பை ஸ்டெப்பா போயிட்டு இருக்கு. பட் அல்டிமேட்லி வாட் ஹேப்பன்ஸ் ஃப்ரம் இது வந்து ஒரு 2019ல நடக்குதுன்னு வச்சுக்கோங்க, ஒரு 2020ல என்ன ஆகுது, சடனா there is a progression, there is a continuous progression of the disease. So that you call it as a secondary progressive multiple sclerosis. That you are going to call it as a secondary progressive multiple sclerosis. What is primary progressive multiple sclerosis? So primary progressive na எடுத்தோன்னே, so இந்த மாதிரி ஜனவரி ஏப்ரல் எல்லாம் போல. So first ஒரு எக்ஸாம்பிள் ஒரு ஸ்பாஸ்டிசிட்டி வருது, கண்டினியூஸா ஒரு இன்கான்டினன்ஸ் வருது, ஒரு விஷுவல் அக்விட்டி டிக்ரீஸ் ஆகுது, அப்படியே சிம்டம் ப்ரொசீட் ஆயிட்டே இருக்குன்னா that you call it as primary progressive multiple sclerosis. So primary progressive multiple sclerosis is a least common subtype and it is a most severe subtype. So what are the 3 subtypes? Again repeat along with me. Relapsing multiple sclerosis, secondary progressive multiple sclerosis, primary progressive multiple sclerosis. So what does your revised McDonald's criteria defines you? So when there is 2 symptoms, so I'll tell you when there is 2 symptoms. Okay, and that symptom is going to last more than 24 hours. Symptoms should be separated by 4 weeks. So these two symptoms has to be separated by 4 weeks or more. Then you call it as a Donaldson criteria. This is McDonald's or revised criteria. This is simple. But I will explain you this. I will decode you this particular tabular column which is present in your page number 1107. So what they tell, 2 or more attack with either objective clinical evidence or at least 2 lesions. The plaques இருக்குன்னு சொல்றோம்ல, அது at least ஒரு 2 lesion இருக்கணும். And there's objective clinical evidence of 1 attack with reasonable evidence of at least 1 prior attack. So 2 attack நமக்கு தெரிஞ்சிருக்கணும். அப்படி இல்லனா 2 or more attack with at least 2 lesions. இது மாதிரி இருந்ததுன்னா எந்த ஒரு அடிஷனல் எவிடன்ஸும் தேவையில்லை. யூ கேன் கால் இட் அஸ் அ மல்டிபிள் ஸ்க்ளரோசிஸ். இல்ல, எனக்கு ஒரு லீஷன் மட்டும் தான் தெரியுது, ஆனா 2 or more அட்டாக்ஸ் வந்து அவங்க சொல்றாங்க கிளினிக்கல் எவிடன்ஸோடனா, அப்ப யூ ஷுட் நோ டு differentiate the dissemination in the space when you're going to see in the MRI. So MRI பார்க்கும்போது ஒரு lesion ஆது at least தெரியணும் with at least 2 of MS typical region. MS typical region என்ன, உங்களுக்கு அந்த paraventricular regionல ஸ்பெசிஃபிக்கா plaques உங்களுக்கு demonstrate பண்ண முடியணும். இல்லனா ஒரு அட்டாக் மட்டும் தான் வந்திருக்கு, not 2 or more attack, ஆனா எனக்கு 2 lesion என்னால ஐடென்டிஃபை பண்ண முடியுது அப்படின்னா along with it there is a dissemination of time. ஓகே, கிளினிக்கலா வந்து அவனுக்கு டைம் டிஃபரன்ஷியேட் பண்ண முடியல அண்ட் எம்ஆர்ஐல ப்ராக்ரஸ் ஆகுது, ஒரு நியூவர் லீஷன்ஸ் வருது. ஆர் ஒரு அட்டாக் மட்டும்தான் இருக்கு, ஒரு லீஷன் மட்டும்தான் இருக்கு, பட் அவனால டிசெமினேஷன் இன் ஸ்பேஸ் இஸ் டெமான்ஸ்ட்ரேட்டட் வித் 2 or more typical regions of MS in your MRI or insidious. உனக்கு எப்ப ஆன்செட் ஆச்சுன்னு தெரியல, எத்தனை சிம்டம் இருக்குன்னு தெரியல, எதுவுமே தெரியல. ஓகேவா, பட் ரேடியாலஜிக்கலி ஐ கேன் டிஃபரன்ஷியேட். அதை தான் நான் அந்த ஃபர்ஸ்ட் ஆன்சர் இந்த லாஸ்ட் 2 இருக்கு பார்த்தீங்களா, இதை வந்து we call it as clinically isolated syndrome and radiologically isolated syndrome. இதை தான் நான் ஃபர்ஸ்ட் எடுத்தோன்னு நான் சொன்னேன், 2 சப்டைப், clinically isolated symptom and radiologically isolated syndrome. ஓகேவா, ஸோ இதுல வந்து just remember what are the things. அதனால தான் நான் ரொம்ப ஈஸியா சொன்னேன், whenever there is 2 symptoms that is lasting more than 24 hours duration, symptoms are separated by 4 weeks and apart, then you call it as a multiple sclerosis. Is it clear? So இதுதான் வந்து basic definition. So when you can understand up to this, finally what we are going to see is, so our patient உங்ககிட்ட வராங்க, how we are going to work out this. So can we move into that segment? Till this, anything doubt is there, please put in the chat box. I can move into the next session. ஓகேவா, ஸோ இப்போ எப்படி ஒர்க் அவுட் பண்ண போறோம். Now எடுத்தோன்னா ஃபர்ஸ்ட் நம்ம என்ன பண்றோம்னா, we are going to ask the patient to get a MRI. So MRIல என்ன நீங்க பாப்பீங்க, Davson's finger. So this is what you are going to look into in the MRI. So there is a Davson's finger or like a plaque like appearance. எங்க மெயினா periventricular area in your white matter, or it can also present in the juxtacortical region or infratentorial region, that is in your cerebellum. Second thing, there is a FLAIR. What is this? Fluid attenuated inversion recovery. So when you're going to suppress the signals of CSF, periventricular lesion will stand up relatively better. So what you're going to do, you're going to suppress the signal of your CSF, that is your fluid, okay, cerebrospinal fluid. அதை நீங்க suppress பண்ணீங்கன்னா periventricular lesion will be standing up and will be visualized better. So that is called as FLAIR. FLAIR, that is going to be called as FLAIR, fluid attenuated inversion recovery. Next you are going to have is a visual evoked potential. So second thing what you are going to do, first MRI எடுப்பீங்க, next you are going to go for the FLAIR. Next what you are going to go for visual evoked potential. So plaque formation small ஆ இருந்ததுன்னா voltage generated கொஞ்சம் decreased ஆ இருக்கும், அதனால latency period will be more. So visual evoked potential latency period more ஆ இருந்ததுன்னா அப்ப plaque formation இருக்கு அப்படின்னு அர்த்தம். Next CSF பாத்தீங்கன்னா there will be slight increase in the protein levels in your CSF, and CSF electrophoresis பண்ணீங்கன்னா when you're going to go for CSF analysis, you will be having an oligoclonal band in your CSF. You will be having oligoclonal band in your CSF. You will be having oligoclonal band in your CSF. CSF electrophoresis பண்ணீங்கன்னா electrophoresis you are going to do, what you will be getting, you will be getting a oligoclonal banned. Okay, next, what is going to be the treatment? So finally, after speaking about all these things, what we are going to go is, we are going to go for the treatment aspect. So when there is an acute attack of optic neuritis, what you have to give? When there is an acute attack of your optic neuritis, you will be giving IV methylprednisolone. Never forget this. So whenever a patient comes to you with the acute loss of vision, what you will be giving is, you're going to go for a IV methylprednisolone. So after giving for the visual acuity loss, then you're going to go for the disease modifying drug to prevent the efficacy of your multiple sclerosis. What all you're going to give? Number one, you will go for beta interferon. So நீங்க இது எல்லாம் நான் வச்சுக்கலனாலும் at least drug name மட்டும் நான் வச்சுக்கோங்க. Beta interferon. Second thing is going to be glatimer acetate. So what is glatimer acetate? It is an immunomodulatory function which is going to be affecting your G for glutamic acid na vachkonga, your T for tyrosine na vachkonga, glatimer. Okay, GLATIMER. So G stands for glutamate. Okay, L stands for lysine, A stands for alanine, T stands for tyrosine. So just remember GLAT. G for glutamate, L stands for your lysine, A stands for alanine, T stands for your tyrosine. In the 4 amino acid modulate panna poranga in the glatimer acetate. Then you have this oral fingolimod. Okay, this is your oral fingolimod. So இது வந்து superior efficacy than your interferon beta. Okay, cardiac conduction defects especially இருந்ததுன்னா இத கொடுக்கலாம் அப்படிங்கறாங்க. Next you are going to have this natalizumab. What is natalizumab? Natalizumab can be given once a month infusion. What it does is, it is going to be inhibiting the binding of your T lymphocyte to the capillaries related to your blood-brain barrier. அப்ப blood-brain barrier damage நம்ம prevent பண்ணலாம். ஓகேவா? So the blood-brain barrier ஓட இத நம்ம prevent பண்ணலாம். Next you are going to have this. Okay, next drug ocrelizumab. Ocrelizumab. What is this? Natalizumab பார்த்தாச்சு. Ocrelizumab na OCRELIZUMAB. Ocrelizumab na, it is going to act by attacking the mature B cells. It is going to be acting by attacking your mature B cells that is going to be expressing your CD20. So இந்த மாதிரி இது வந்து எங்க யூசுவலா காமனா இருக்கும்னா primary progressive multiple sclerosis. அங்கதான் எடுத்தோன B cells are going to be affecting. So that is going, அங்க வந்து நீங்க என்ன ட்ரக் கொடுக்குறீங்க? ocrelizumab கொடுப்பீங்க. So mitoxantrone அப்படின்னு ஒரு ட்ரக் இருந்தது. ஓகேவா? மிட்டாக்சான்ட்ரான் இதுதான் வந்து ஃபர்ஸ்ட் யூஸ் பண்ணிட்டு இருந்தாங்க. பட் இது வந்து கார்டியோடாக்சிக்கா இருக்கிறதுனால இப்ப மல்டிபிள் ஸ்க்ளரோசிஸ்ல யூஸ் பண்றது இல்ல. இப்ப ட்ரீட்மெண்ட்ல நம்ம என்ன எழுத போறோம்? இன்டர்ஃபெரான் பீட்டா, glatimer acetate. Then you are going to talk about the oral fingolimod, oral dimethyl fumarate. Oral dimethyl fumarate பத்தி கூட பேசலாம். Next you are going to have this natalizumab. Natalizumab வந்து பாத்தீங்கன்னா it's a once a month infusion which is going to affect your T cells. அப்ப B cells யார் கண்ட்ரோல் பண்ண போறாங்க? ocrelizumab. ஓகேவா? So இத மட்டும் எக்ஸாம்ல எழுதுங்க. No, nothing more than this is required from your Davidson. So already Davidsonல என்னென்ன கொடுத்திருக்காங்களோ அதை மட்டும் தான் I have told you. So how to demonstrate இது எல்லாமே they have given. I think we have talked about all these clinical features, isn't it? Lermite sign பார்த்தோம், postural tremor பார்த்தோம், recurrent facial palsy ஏன் வருது, subacute loss of function of upper limb ஏன் வருது, acute brainstem syndrome ஏன் வருது, எல்லாமே நம்ம பார்த்திருக்கோம். Okay, investigations நம்ம பார்த்தோம். Management also we have seen. Managementல acute episodes இருந்ததுன்னா நம்ம என்ன கொடுக்கணும்? Intravenous Okay, IV methylprednisolone should be given. Disease modifying agent அதான் நம்ம tabular column பார்த்தோம். Treatment of symptoms, complication and disability. Individually you are going to act on it. Individually you are going to give எப்படி? Spasticity. Physiotherapy கொடுப்போம் and beclofen கொடுக்கலாம். Dysasthia அதுக்கு என்ன கொடுப்போம்? gabapentin can be given. Bladder symptom what we will be doing? For bladder symptom we will be giving the bladder இது பண்றது அது we will be giving. Okay, the sphincter relaxants கொடுப்போம். Fatigue இருக்கு அப்படினா we will be giving amantadine. Erectile dysfunction க்கு sildenafil 50 to 100 mg per day we will be giving. Okay, in case pregnancy அப்ப multiple sclerosis வந்தா okay relapse risk பத்தி நம்ம explain பண்ணோம். disease modifying drugs, like your risk of teratogenicity is there. So around 6 to 8 weeks we have to stop before the conception, and recommended only after breastfeeding. Okay, wow. So with this, I'm completing this multiple sclerosis. If you have any doubt in the multiple sclerosis, you can put in the chat box, or after this class, you can put in the our group also. So there is another group link which I have in the same your Medusane 2019 group. So which is meant for discussion. You can also join in that, and you can ask any question, or you can ultimately PCS so that we can also answer your questions. So this multiple sclerosis is a very important topic as far as your exams are concerned. Already they have asked around 2 times, I guess. So adanala multiple sclerosis is very important. Concept புரிஞ்சா ரொம்ப ஈஸியா இருக்கும். So in the next 5 minutes we will just briefly summarize the entire thing, and we can just go for complete the session. So what is a multiple sclerosis? Number one, it is going to be produced by the demyelination. So you have to understand the difference between the demyelination and dysmyelination. Dysmyelination na myelinate produce agala from the beginning itself. Demyelination na because of inflammation there is going to be a demyelination. So inflammation ku enna cause irukala nama paathom. Rendu cause da genetic, environment. Genetic na HLA DRB7 DRB1 ivar da major cause. Environmental factor rendu paathom. Epstein-Barr virus onne, vitamin D deficiency onne. So what happens? There is going to be damage of your myelin nerve sheath. So myelin nerve sheath damage ஆகுது, உங்க blood brain barrier ல போய் attach ஆகுது, capillary supply பண்றதுல உங்க endothelium ஓட blood vessels ல you have this CAM integrin molecule, and the integrin வச்சு attach ஆகுது. Once it is going to get attached, what it is going to do? It is going to cause a T cell mediated cytokine release. என்ன cytokine release ஆகும்? TNF alpha. So TNF alpha என்ன பண்ணும்? Nitric oxide release பண்ணும். What it is going to do? It is going to cause axonal degeneration and neuronal loss, demyelination. So இது எல்லாம் எழுதினோனே அதுக்கப்புறம் what you are going to do is you are going to go for the axonal degeneration ஆகுது. அப்புறம் B cell பார்க்குறோம். B cell என்ன பண்ணுது? பிரெயின்ல போய் MOG ப்ரொடியூஸ் பண்ணுது, myelin oligodendrocyte glycoprotein. இந்த myelin oligodendrocyte glycoprotein is going to be not a villain, but it is going to be acting for the body, for ourselves, but it is going to turn against it. எப்படின்னா ரிப்பேர் ப்ராசஸ் ஸ்டார்ட் பண்ணுது, பட் oligodendrocyte இல்ல. அப்ப வெறும் உங்களோட ஆஸ்ட்ரோசைட்ஸ் மட்டும் தான் இருக்கு. அந்த ஆஸ்ட்ரோசைட் is going to do gliosis. What is a gliosis? There is a plaque formation in the periventricular area. So periventricular area plaque formation ஆகிறதுனால நிறைய சிம்டம் வருது. அதுல ஒண்ணுதான் ophthalmoplegia. Ophthalmoplegiaல நம்ம 1.5 syndrome பார்த்தோம். What is 1.5 syndrome? Again I repeat, 3 important thing நிறைய இருக்கு, பட் 3 important தான் நம்ம வச்சுக்கணும். ஒன்னு, there is a ipsilateral sixth nerve palsy, ipsilateral median fasciculus palsy. So அதுக்கப்புறம் வந்து பாத்தீங்கன்னா contralateralல வந்து adduction நடக்காது, only abduction is present. Because of this what happens? There is going to be a 1.5 syndrome. அதுக்கப்புறம் நம்ம என்ன பார்த்தோம்? sensory systemல paresthesia இருக்கலாம், pin needle sensation இருக்கலாம். அதுக்கப்புறம் facial nerve palsy இருக்கும், twitching of muscles இருக்கும். Then there is a spastic weakness of the upper limb and your lower limb. அங்க எப்படி இருக்குன்னா upper motor neuron lesion மாதிரி present பண்ணும், ataxia இருக்கும். So அங்கதான் நம்ம என்ன பார்த்தோம்? We have seen very important thing, that is a Charcot's triad. What is a Charcot's triad? So it is going to be ataxia, dysarthria and tremor is going to be present. So 8th nerve காது கேட்காது. So glossopharyngeal nerve நால what happen? Pain on swallowing, trigeminal neuralgia, 5th nerve palsy. Then you have this Lermit sign, neck flexion ஆகிறப்ப limbல எல்லாம் உங்களுக்கு radicular shooting pain இருக்கும். Then detrusor hyperreflexia. Then you are going to have detrusor sphincter dyssynergia. அப்ப sphincter work பண்ணாது. அதுக்கப்புறம் நம்ம என்ன பார்த்தோம்? Expanded disability severity scoring பார்த்தோம். Next we saw about the relapsing multiple sclerosis, secondary progressing multiple sclerosis, primary progressing multiple sclerosis. Then we have talked about the revised McDonald's criteria. Then how we are going to work up னு பார்த்தோம். Finger like projections will be present, plaque will be present, visual evoked potential there is going to be increase in the latency period. So CSF ல electrophoresis பண்ணி பார்த்தோம்னா அங்க we can see oligoclonal bands. So what is going to be the drug? Now Deepak's question I will come to. We will have to write the drug dosage or name of the drug. Name of the drug is வெறும் enough தான். So drug dosageல எதிர்பார்க்க மாட்டாங்க. Name of the drug and action of the drug அது ரெண்டும் நீங்க மென்ஷன் பண்ணணும். பீட்டா இன்டர்ஃபெரான், கிளாட்டிமர் என்ன பண்ணுது? GLAT நான் வச்சுக்க சொன்னேன். குளுட்டமிக் ஆசிட், அலனைன், லைசின், then you are going to have tyrosine. இது 4 அமினோ ஆசிடோட இது வந்து ப்ராப்ளம் ஆகுது. So because of it there is going to be a problem. So then oral fingolimod இருக்கு, அப்புறம் oral dimethyl fumarate எடுத்துக்கிறோம், natalizumab எடுத்துக்கிறோம். natalizumab என்ன பண்ணுது, உங்களோட T lymphocyte bind ஆற அந்த integrin part வந்து it is going to affect, therefore damage to blood brain barrier is reduced. Then you go for the you have this ocrelizumab. What does ocrelizumab do? It is going to attack the mature B cells, therefore it is going to be helpful in the PPMS, that is primary progressive multiple sclerosis. I hope it is clear. This essay you are going to write very neatly, very clearly. In the essay exam la ketana, I hope that everyone should attend this. Okay, if you have any doubt or any query, feel free to PC me, or you can put it in the group or in the comments so that I can answer you. Okay, is it clear? So tomorrow what we can see is, tomorrow I will start with another essay question, that is Parkinsonism. So Parkinsonism I will just try to teach you all. So already Alzheimer's, I don't think so they will ask you again, because Alzheimer's was asked in my exam also, so probably they won't ask in your exam again repeat. So but CNS is very important, because every year we are expecting one question from CNS, and this question is very important because they are like there are lots of things to ask in your CNS alone. Cardiovascular system na very limited number of questions தான் இருக்கு, GIT la limited number of questions தான் இருக்கு, but CNS is not like that. It's a huge topic, you can they can ask from anywhere, so newer questions can be expected from your CNS. So just get prepared and we will try to make it easy for you all. Thank you so much. If you can if you have understood well, just put it in the chat box, and we will see if you have any doubt, so that I can explain you in the next class or in your group. Okay, thank you so much.